Tarasova. It is my pleasure to introduce Dr. Valentina Tarasova. She is an endocrinologist at Moffitt Cancer Center in Tampa, Florida. Dr. Tarasova's clinical interests include thyroid neoplasm, particularly diagnosis, monitoring, and treatment of thyroid carcinoma, from low risk to advanced progressive forms of thyroid cancer. Her research interests include the role of molecular markers in diagnosing and determining the prognosis of thyroid neoplasm, risk stratification of patients with thyroid cancer, and developing tools to estimate the prognosis and determine the management of patients with thyroid cancer. And with that, I welcome Dr. Tarasova.
Thank you so much, Matt. It's a pleasure to present at the ThyCa meeting. I am grateful to the organizing committee for inviting me to participate, and to ThyCa Society for being the leaders in the field when it comes to the patient education and patient support for patients with thyroid cancer. So today we'll talk about the questions that you may have about different thyroid cancer types and variants. I don't have any disclosures. I would like to note that most of the pathology slides was obtained from the Pathology Outlines website. And my biggest disclosure is that I'm enthusiastic and committed to the thyroid cancer, to treatment of patients with thyroid cancer. I will start my presentation with the WHO classification of thyroid neoplasm that was updated in 2022. This is that classification includes benign lesions, low risk neoplasm, and malignant thyroid neoplasms. Today we will focus on malignant thyroid neoplasm based on most recent WHO classifications. So based on that classification, we have follicular thyroid carcinoma, oncocytic thyroid carcinoma, the carcinoma of the thyroid. This is a new entity and it has a new name. That was previously known as Hurthle Cell carcinoma or oncocytic type of follicular thyroid carcinoma. Then there is invasive encapsulated follicular variant papillary thyroid cancer, and of course papillary thyroid carcinoma. High risk thyroid cancers are differentiated. High-grade thyroid carcinoma is also a new entity based on this new classification, as well as poorly differentiated thyroid carcinoma. And that is all group that includes differentiated thyroid cancer. Then there is also anaplastic thyroid cancer that considered to be undifferentiated and the most aggressive one. In 2023, the talk about thyroid cancer is not possible without touching on the genomics of thyroid cancer. And there are two main pathways that are activated in the pathogenesis of thyroid cancer development. One is the MAP kinase pathway, and another one PIK3 AKT pathway. So MAP kinase pathway is activated through BRAF or RAS genes and RAD PTC fusions, and primary is involved in development of papillary thyroid cancer. On the other hand, PI3K AKT pathway is activated through RAS or AKT1 or PTEN or PIK3 ACA point mutations, and this is leads to development of follicular thyroid carcinoma, follicular thyroid adenomas, and carcinomas. When there are more mutations that acquired by the cancer, then it progresses to poorly differentiated thyroid cancer, and with the later at anaplastic thyroid cancer. Genomics of follicular cell thyroid cancer could be divided in three categories. First one is BRAF-like, second one is RAS-like, and then non-BRAF, non-RAS type of thyroid cancer. And why is it important? Is because biological behavior of the tumors differs significantly, whether it's BRAF-driven or RAS-driven tumors. And all the other non-BRAF, non-RAS also has their specifics of behavior. So this is in general the beginning of the thyroid cancer development, and then later on we have additional mutations. Thyroid cancer has another mutations such as TP53, TERT, CTNNB1, AKT1 mutation. That's all leads to further the differentiation and progression to more aggressive types of thyroid cancers. That slide summarizes the spectrum of thyroid cancer that patients have, coming from well-differentiated papillary or follicular oncocytic type of thyroid cancer, then to the differentiated, poorly differentiated, differentiated high-grade, and eventually anaplastic thyroid cancer. With the progression of disease, mutational burden increasing, as well as that there is decrease of response to radioactive iodine therapy, decrease of expression of the sodium iodine expression by the thyroid cancer cells, and the PET avidity is increasing as the cancer becomes more aggressive and differentiated. If we look at all thyroid cancers, so we have most of that vast majority is represented by papillary thyroid carcinoma, about 80%. And the rest is divided between other types of thyroid cancer, such as follicular thyroid cancer, oncocytic carcinoma of the thyroid, medullary thyroid carcinoma, poorly differentiated, and anaplastic is a very rare one. So now let's talk about different subtypes of papillary thyroid carcinoma. Previously, they were called variants, and based on the most recent classification, now they are called subtypes. These are the currently defined subtypes, such as infiltrative, follicular subtype, tall cell subtype, columnar cell subtype, hobnail, solid, diffuse sclerosing, Warthin-like, oncocytic. All these subtypes are based on the histological presentation, based on basically what does pathologist sees under the microscope. So, and we'll talk a little in a greater detail about each of them. Classical papillary thyroid cancer. This is what most people think when they talk about thyroid cancer. That has specific characterized by branch and papillary with fibrovascular cores. It has also typical nuclear features, has these samoma bodies, which is like small areas, necrotic areas within the thyroid gland, and it's very well recognized, and this is the one that has the best reputation. That's the type of thyroid cancer that has the best prognosis, has the best clinical outcomes, considered to be the slowest growing, the least progressive one. And this slide is from the SEER database, from the National Database on Thyroid Cancer Survival. And from here, we can see that if we take all the cancers, which are mostly represented by papillary thyroid cancer, we can see that 98.5% of patients with thyroid cancer survive in 5 years. And that's the statistics for classical PTC. And we can see that mortality remains overall stable over years, and this is the trend of the detection rate. So we were increasingly more detecting that cancer, but now the detection rates are slowing down because we are more selective in patients who we biopsy and don't biopsy really small lesions. Now we'll talk about more aggressive types of different types, subtypes of thyroid cancer, and this. Next couple slides will be about tall cell subtype PTC. So tall cell is defined based on the presence of that specific tall cells that appear to be taller than two or three times taller than white. That specific cells need to be seen in more than 30% of the thyroid cancer of the specimen. Previously, it was more than 50%, but this criteria is quite subjective. It's objective criteria, but interpretation of that could vary between different pathologists when they look at the same slides. So they also characterized by that abundant granular eosinophilic oncocytic-like cytoplasm, that tall cell variant, tall cell subtype thyroid cancer has that specific tram track appearance when all railed roll patterns. So it could be well recognized under the microscope. Sometimes we see that patients have these tall cells. However, the number of tall cells are not quite enough to qualify for tall cell variant. Then it called subtype. Then it called tall cell features. When there are presence of there is more than 10% of this tall cell present. But even the features is considered to be more worrisome prognostic factor for the thyroid cancer. So overall, tall cell subtype is present in about 5 to 10% of all papillary thyroid cancers. Usually, it is seen in older patients, and it is exceedingly rare to be seen in young pediatric population. Tall cell variant was shown to be more aggressive behavior in classical PTC, independent of age, gender, or tumor size. Often, but not always, larger tumor sites are more frequent, has more frequent extrathyroidal extension when the cancer grows outside the capsule of the thyroid gland. And there is, with tall cell variant, there is more common to have lymph nodes involved. And then these tumors, these cancers are higher at higher grade at presentation compared to patients with classical PTC. The patients with tall cell subtype had higher recurrence rate. They have higher mortality than a classical PTC. That this tall cell subtype of papillary thyroid cancer accounts for about 20% of radioactive iodine refractory tumors. We know in clinical practice they don't uptake iodine, and that's a challenge in the management of this patient. They're also not a good producers of thyroglobulins, so thyroglobulin marker may not be as reliable in patients with tall cell variant. However, that's not that has to be also, again, interpreted in the clinical setting. Most of the patients with tall cell subtype has this BRAF V600E mutation. And they also have frequency of other mutation, like third promoter mutation, than classical PTC. It's higher that's seen at 5 to 30% versus 10% that is seen in PTC. So now we'll talk about diffuse sclerosing subtype of papillary thyroid cancer. This is also a quite uncommon type of papillary thyroid cancer, but when we see that, it's definitely come with its specific clinical pathological features as well as specific biological behavior. When we see this diffuse sclerosing variant, from the name, you can see that the whole gland is typically involved. So it's not that it's like one spot of thyroid cancer that we see, but the whole gland is infiltrated by cancer. And there is, at the presentation, there is higher rate of the cancer spreading outside the capsule of the thyroid gland. The lymph node metastases are very, very common, seen in almost all the patients. About 70 to 90% of all the patients have this lymph node metastasis as a presentation, and distant metastasis is in about 12% of patients. And mainly it's at the lungs. And this is typically, this is younger patients, and typically it's associated with red PTC fusion rearrangement seen in 60%. So could be associated with some radiation exposure. That type of thyroid cancer we see frequently in younger individuals and in females, and it's frequently seen in females with Hashimoto thyroiditis. So to have positive thyroglobulin antibodies is very common in the patient with diffuse sclerosing variant papillary thyroid cancer. This patient has, even though the patient have more commonly they recur, however, their life expectancy is not significantly different from regular conventional papillary thyroid cancer. However, they have shorter disease free survival, which means that cancer come back earlier, and we can see recurrences when with the patients who are diagnosed with diffuse sclerosing variant. However, treating this recurrence then does not really affect the survival. So overall, there are some nuances into that. And you can see that here that there is like pathology slides, there is some lymphocytic infiltrates, and then there is multiple these samoma bodies, which is in classical, there are very few, but in this diffuse sclerosing variant, there are many samoma bodies in the specimens. Now let's talk about columnar cell papillary thyroid cancer, which is another subtype of papillary thyroid cancer, which has typically more aggressive way of aggressive behavior. So again, all these names is coming from the appearance of that thyroid cancer cells under the microscope. So that cells appear to have this columnar appearance, and they have that they have prominent nuclear stratification, but they don't look necessarily like papillary thyroid cancer. So it's a very rare subtype of papillary thyroid cancer, but clinicians need to recognize that, because when they see this type of thyroid cancer, that should warn them that it can behave more aggressively than classical papillary thyroid cancer. Less than 1% of all papillary thyroid cancer is caused by that columnar cell. Typically could be seen among all age groups, but usually all the patients. Usually it presents with the extrathyroidal extension, cancer growing outside the thyroid gland, and lymph node metastasis seen in about half of the patient at the presentation of columnar cell. Distant metastasis is also seen in up to 5% of patients at presentation, which is a little bit higher than with classical PDC. There is also higher risk of local recurrence, meaning cancer coming back in the neck. And they typically present with more advanced staging when they're at presentation, when they're at diagnosis. In general, kind of, so the next subtype of papillary thyroid cancer is hobnail. And I know it could be overwhelming to see all these different subtypes of thyroid cancer, but the idea is that there is really not one type of, when you say patients, when they say that there is one type of thyroid cancer, it doesn't work. Like when they say that it's papillary thyroid cancer, there is, different variants, and each of that variant has its nuances in the way it behaves. So it's very important for clinicians to recognize these subtypes and adjust the follow-up and treatment accordingly to that specific subtype. So one size does not fit all, even if it's just papillary thyroid cancer, not thyroid cancer in general. So let's talk about hobnail subtype. Hobnail is also moderately differentiated. If we say that papillary thyroid cancer classical is well differentiated, that is moderately differentiated. So it's kind of on the way to that poorly differentiated, undifferentiated type of cancer. So it is placed in between differentiated PTC and poorly differentiated thyroid cancer. It's BRAF, V600T is likely the driver. However, there is more of that additional mutations that are seen that are causing that the differentiation and more aggressive behavior, like TP53 and third promoter mutation. Yes, I have a question. We talked about it briefly, but this is one of the ways how, like this is the mutation that could cause during late stage of development of cancer, and it definitely is seen in more aggressive types of thyroid cancer, and it's can go in combination with other mutations too. So that hobnail subtype is also seen when it presents, is also frequently extends outside the thyroid capsule. Many times is already in the lymph nodes in up to 75%. Already into up to 40% of the presentation, it can be already spread to the lungs and brains and bones. It also frequently recurs in the neck. It could be, if let untreated, that could potentially progress to poorly differentiated thyroid cancer. And it's also seen with advanced clinical staging at the time of presentation. And it has increased mortality rates, higher mortality rates compared to classical PDC, but not in all cases. Then there is another type of thyroid, subtype of thyroid cancer, which is solid subtype, which is also characterized by that specific growth pattern with papillary thyroid papillary thyroid cancer features on cytologic features, but there is no really evidence of necrosis in this tumor. Again, this is a very rare subtype. In children, it's solid or trabecular variant is very common, and it has a high risk of relapse. It's also seen after radiation, after post-Chernobyl cases, and associated with the RET PTC3 mutation, fusion. This is associated with a poor prognosis and slightly high risk of spread outside the neck compared to classical PTC, but its prognosis better compared to really that poorly differentiated thyroid cancer. So it's in between. Then there is another subtype of papillary thyroid carcinoma called oncocytic. That's not to be confused with oncocytic thyroid carcinoma, or formerly known as Hurthle cell carcinoma. This is papillary thyroid carcinoma that has that oncocytic type of cells. It's a very rare type. It's less than 10%, but probably it's less than 0.5% altogether. It's characterized by nuclear features of papillary thyroid cancer, and then oncocytic or Hurthle cell-like cytoplasm. So that has features of both, but it behaves more like papillary thyroid cancer. And then it's associated with lymphocytic Hashimoto thyroiditis, and it's mostly commonly seen in women. Another exotic type of papillary thyroid cancer is Warthin-like. The name is unusual, and the name is common because it mimics Warthin type of tumor. When pathologists see that the slides, they look that papillary thyroid cancer. It looks a lot like salivary gland tumor, and that's why it comes the name, because there's Warthin tumor of salivary glands, and that papillary thyroid cancer looks like that on the microscope. It has typically more favorable prognosis, and it's commonly associated with also lymphocytic Hashimoto thyroiditis and positive thyroglobulin antibodies. So in general, thyroid cancer, just a couple words about papillary thyroid cancer before we will talk about follicular thyroid carcinoma. Papillary thyroid cancer is very predictable. The first place is it's in the thyroid, of course, and then it goes to the lymph nodes in the neck, typically on the side where the cancer is, then on the other side, and then it progresses to the mediastinal lymph nodes, and then lungs, and then elsewhere. So understanding the type of thyroid cancer it is helps to predict a lot biological behavior of cancer, and helps us to understand how to monitor it, where to expect it. That's why the management a lot differs, and there are some specifics that we know how we follow papillary versus other types of thyroid cancer. And even within the papillary thyroid cancer, knowing what type of thyroid cancer, what genomic abnormality it has, it helps us to understand what to expect from that thyroid cancer. So now we'll talk about completely different type of thyroid cancer, follicular thyroid cancer. Right, so this is second most common type of thyroid cancer, and this is characterized by follicular differentiation, and there is no papillary nuclear features. It accounts for about 6 to 10% of all thyroid carcinomas, and it's typically activated PI3K, AKT, or RAS receptor tyrosine kinase signaling pathway. NRAS or HRAS mutations seen in 49%, probably even higher rates in the vast majority of the patients. Then there is the second most common mutation is PAX8 and PPR gamma rearrangements. And then PI3CK and PTEN mutations are seen in about 5 to 10% of the patients with follicular thyroid carcinomas. When we talk about follicular thyroid carcinomas, it is essential to understand how do we classify this type of thyroid cancer, because prognosis and management will differ significantly based on this classification. And this WHO defines it very well. So now it's classified, the follicular thyroid carcinoma could be classified as minimally invasive, encapsulated, angioinvasive, and widely invasive. So when we talk about follicular thyroid cancer, they're typically covered by the capsule. And that capsule, if it just follicular growth pattern and covered by capsule, that's follicular adenoma. But the moment that there is invasion to the capsule, that means that it's follicular carcinoma, and it's minimally invasive because that's capsule invasion. And that figure reflects it. So this is the capsule in green that's surrounding follicular neoplasm. And then there is different extent of capsular invasion that could be seen in this lesion. And that what helps to define follicular carcinoma. And then what is also important to see that like there is also follicular neoplasm within the capsule, there could be also vascular invasion. And what is very important to understand how many foci of vascular invasion are there with the how many foci of vascular invasion are there present. For that, pathologists need to examine the whole capsule of that follicular neoplasm and count each of that foci of vascular invasion, because if there is less than 4 foci, interestingly, the cancer will behave very well. And there is no need for additional therapies, and prognosis is excellent, and the risk of recurrence is less than 5 to 10%. And overall patient the cancer behaves very well. On the other hand, if it's more than 4 foci of vascular invasion, that pushes the cancer to high risk, and then there is high chance of the cancer spread. And if it's spread, it typically does not go to the lymph nodes. It typically goes outside the neck, to the bones, to the lungs, other parts of the body. And then it's definitely, puts like more than 40% risk of cancer to be recurred. So in this case, we need to be more aggressive in terms of management. That's when we consider additional therapies. Let's say if the 3 patients were just treated with removal of the half of the thyroid, if we find more than 4 foci vascular invasion, that means that the cancer, that the additional lobe needs to be removed, and we typically treat with patients with radioactive iodine. So very important to recognize that. This is examples of like that encapsulated follicular thyroid carcinoma. And you can see that really nice capsule, and there is like areas of capsule invasion. And then this is widely invasive, when basically with capsule, there is not capsule is with multiple areas of invasion. And sometimes that the growth of that follicular carcinoma could be outside not only the capsule of the lesion itself, but also of the thyroid itself, invading surrounding tissues. So follicular carcinoma may arise from pre-existing adenoma, right? So sometimes it's difficult to recognize, frequently actually, it's difficult to diagnose follicular carcinoma just on the FNA biopsy. Many times, when we biopsy the thyroid nodule, it comes back as indeterminate, but that's the category 3 or category 4. And then, because in order to really see if it's cancer or not, we need to examine that capsule, and there is no way how we can examine that capsule based on the needle. So that's why, removal of the thyroid and looking at it under the microscope will give us more definitive answer. Follicular thyroid carcinoma does not spread, metastasize through lymphatics, but it's more spread through the hematogenously, and it's spread to lungs, liver, brain via blood vessels. Exceptionally rare when we see lymph nodes with follicular thyroid carcinoma. That's why ultrasound of the neck, even though routinely commonly done in a follow-up of follicular thyroid cancer, may not be as helpful to really diagnose the diagnose the recurrence, because they will not show up in the lymph nodes in the neck. However, they are good producers of thyroglobulin. Typically, they're good producers of cancer marker thyroglobulin, and we can follow the trend over time. And typically, combination of that and initial risk, understanding what initial risk of it helps us to monitor this type of cancers. When it comes to distant metastases, almost 70% are seen in the lung and bone. So minimally invasive follicular thyroid carcinomas, the one that has only capsule invasion and the one that has very few fossa vascular invasion, they have excellent prognosis and they have very low long-term mortality. On the other hand, that widely invasive has much higher risk mortality. Poor prognosis associated with tumor size greater than 4 centimeters, distant metastasis, of course, in presentation. The older the patient, that the prognosis is worse. The bigger the tumor, that's associated also with worse prognosis if there's extensive vascular invasion and extrathyroidal extension. It's very important to understand, to know who is the pathologist, who is reading that, and if they really examine the whole capsule. Because we work, like I work in the tertiary institution, and sometimes we review the slides. We actually routinely review the slides on all the patients who come to our institution, and the outside reports come and they just send the selective slides. So we need to examine the whole capsule to be really definitive to understand the prognosis of follicular thyroid neoplasm in general. So now we will talk about follicular carcinoma and follicular adenoma as part of that. And they are very similar in a way when it's with follicular thyroid cancer, but they also very different. And previously, they were actually in the one group, then it was called oncocytic type of follicular thyroid carcinoma. But now it's a separate entity and it's oncocytic carcinoma of the thyroid, OCA. So before we'll talk about oncocytic thyroid cancer, I would like to talk about oncocytic adenoma and these Hurthle cells that creates a lot of confusion and a lot of worries among the patients. Because when we see, oncocytic adenoma, it's basically typically encapsulated lesion or with oncocyte, or otherwise called Hurthle or oxophilic or Ashkenazi cell, which is just the way how they appear in the microscope, large cells with abundant glandular eosinophilic neoplasm or cytoplasm. Oncocyte means swollen in Greek, so they appear to be a little bit more rounded nucleus, and these cells appear to be, you see, like a little bit swollen and a little bit bigger. And the fact that the Hurthle cell are present, it doesn't mean that this is Hurthle cell cancer. And this is very important to understand, because Hurthle cells could be present in the setting of Hashimoto thyroiditis, Graves' disease, just after inflammatory, some post-inflammatory changes after FNA biopsy. So the presence of Hurthle cell does not define the diagnosis of Hurthle cell carcinoma. But what defines it is, again, similar to how it was in the follicular thyroid cancer. What defines it, the presence of capsule invasion or presence of vascular invasion. So, and it's also classified in a similar way to the follicular thyroid cancer, when we have minimally invasive, when they just capsule invasion, when the capsulated angioinvasive, there is less than 4 foci vascular invasion, and widely invasive, that there are more than 4 foci vascular invasion, and could be extension outside the growth outside the thyroid capsule. Oncocytic carcinoma of the thyroid is oncocytic adenoma is benign, and there is no recurrence of excision, but oncocytic adenoma can progress to oncocytic carcinoma if there is like that invasion. Overall, oncocytic carcinomas are more aggressive than conventional follicular thyroid carcinoma, with high frequency of extrathyroidal extension, local recurrence, metastasis to lymph node. They typically progress at later stages, stage 3 and stage 4. They have high mortality. They the worst prognosis associated with old age, with the bigger tumors, more than 4 centimeters, with extensive vascular invasion, also with gross extrathyroidal extension. Genomics are very distinct from the follicular thyroid cancer, and the behavior is different, and avidity and sensitivity to radioactive iodine is very different. If follicular thyroid cancer, the one that are RAS driven, are very sensitive to radioactive iodine, and they are typically great responders, that oncocytic type of, they are not sensitive to radioactive iodine, they're refractory, exceptionally rare, they respond to radioactive iodine. So they have distinct genomic composition. They're typically driven by chromosome gains or losses or deletion and mutations of mitochondrial DNA, also PTEN and T53 mutations. A distinct category now is invasive encapsulated follicular variant PTC. This is different category. This is not follicular variant PTC that was used to be in the past. This is a different one, and it's behaves similar to more to follicular thyroid cancer and classified accordingly: minimally invasive, encapsulated, angioinvasive, and widely invasive. So that concludes we covered papillary thyroid cancer, follicular thyroid cancer, and oncocytic thyroid carcinoma. We still have to cover two types of high-grade, like more aggressive types of thyroid cancer. I'll touch base on anaplastic, and we'll talk about different, just unusual types of thyroid cancer. So differentiated high-grade thyroid carcinoma. This is also a newer entity. This is is a very aggressive type of thyroid cancer. They have features of PTC. They differentiated, so they have features of PTC, follicular thyroid carcinoma, oncocytic thyroid carcinoma, but they have also high-grade features that associated with poor prognosis. They have mitotic rate, they have tumor necrosis. They look like poorly differentiated. However, they have differentiated features of papillary thyroid cancer. So these two poorly differentiated high-grade, some of the features overlap. However, there is the distinct thing about high grade is that it had really differentiated features of a different type of cancer. It has worse prognosis, much worse prognosis compared to DTC, and it's kind of like a step before the anaplastic thyroid cancer. Then poorly differentiated thyroid cancer is another very aggressive type of thyroid cancer. It is seen in all the patients. It is typically, it's seen in up to 1 to probably like 7% of thyroid carcinoma. It typically presents with a big thyroid mass. Patients have history of recent growth in long-standing uninodular or multinodular thyroid glands. So it's something that's been there for some time, and at some point just start to progress and grow. So it's in between, as I said, like well-differentiated thyroid cancer and anaplastic thyroid cancer. It's typically at the presentation, commonly it's already invaded surrounding tissues. It has frequently that vascular invasion, regional lymph nodes are there at presentation, distant metastasis is there in up to 40 to 70% of the patients, and they are driven typically by RAS or BRAF or RAS mutations, and then it's associated with the differentiation such as mutation of TP53, TERT, and beta-catenin pathway, and like AKT mutation. So all that is associated with the late hit mutations. Just, there is the whole presentation could be done on anaplastic thyroid cancer, but for the purposes of the talk, I cannot not touch on that. So anaplastic thyroid cancer is the most aggressive form of thyroid cancer, one of the most aggressive malignancies that in a human being in general, that composed of undifferentiated follicular thyroid cells. It's even though it represents only for less than around 1.5% of all thyroid cancer, it contributes to half of the people who die from thyroid cancer, it's dying from anaplastic thyroid cancer. So even though that's very rare, but it's it's very, very aggressive and very worrisome. Typically, it's seen in all the patients. Then it's higher seen in patients who in area of iodine deficiencies, and United States is not one of that areas. Its median survival 1 year is 10 to 20%. Historically, it's been like 3 months. However, now with advancements, when understanding more molecular genomics of thyroid cancer and newer therapies development, that has been pushed, and patients with anaplastic thyroid cancer definitely has much much better prognosis now compared to how it was even like 5 years ago. And all anaplastic thyroid cancer stage 4 presentation. So like regardless of where it is, even if it's very, really tiny focus of anaplastic thyroid cancer, it's stage 4 by definition. Now, just some maybe confusing terms, but I would like to clarify them and, like what is this papillary microcarcinoma? Papillary microcarcinoma is basically the name for the all papillary thyroid cancers that are 1 centimeter or less. Could be any subtype, could be, let's say, tall cell variant. It would be rare to see like other like hobnail, columnar type of thyroid cancer to be that small and be really caught at that papillary thyroid small, but by definition, it's 1 centimeter or less. It's the most common variant of papillary thyroid cancer in US in general. In general, papillary thyroid cancer is present in up to 14% of people. So whether we know about it or no. So in autopsy studies, they seen that thyroid cancer is there. It just sometimes it's really, really tiny foci, but it's not uncommon. So that's the type of majority of the papillary microcarcinomas. When they 1 centimeter or less, they typically behave very well, and they have they typically remain stable over years. Active surveillance has been formally considered as a way to manage papillary thyroid cancer, papillary microcarcinoma. So not all of them need to be removed. Small thyroid cancer can be watched. And tall cell variant papillary thyroid cancer, even though it's associated with more aggressive features, however, there is big debate whether tall cell itself, in the absence of other features such as lymph node metastasis, extension outside the thyroid capsule, invasion to surrounding tissues, like whether tall cell itself really puts papillary microcarcinoma at high risk. So there is debate about that. So, and just for you to have some relevance, it's a little bit bigger than one dime. So now there is thyroid cancer can be in different places. So we talked about types of thyroid cancer that are typically seen in the thyroid. But thyroid cancer can leave not only the thyroid, sometimes it's diagnosed in thyroglossal duct cyst. So thyroglossal duct is the most common developmental abnormality of the thyroid gland and the most common congenital neck mass. So thyroid during embryological development, it's formed in the base of the tongue, and then it descends to the base of the neck, and there is a pathway where it descends, but sometimes that path is not closed, and then there is like this cystic formation which called thyroglossal duct cyst. Sometimes there's thyroid tissue, and if there is thyroid tissue, there could be cancer within this thyroid tissue. So it's just that the thyroid cancer could be seen not only in the thyroid, but it could be the same papillary, everything that we discussed above, even though I never seen actually anything other than papillary thyroid cancer in thyroglossal duct cyst, but that could be something that just unusual location. The same thing with stroma ovary. This is where papillary thyroid cancer, this is where thyroid cancer could be seen in the ovary. Stroma ovary is a rare ovarian teratoma composed entirely predominantly of thyroid tissue, and majority of them are benign. So, but sometimes there could be thyroid cancer in that stroma ovary. It's typically diagnosed because stroma, they just find it on the pelvic ultrasound, and there is ovarian mass, and then they remove that, and then there is thyroid cancer. So then there is a question, what do we do about that? How we deal with the thyroid? Does radioactive iodine necessary? It's just the same thyroid cancer, but just in an exotic location. So, but that's stroma ovary. Perfect. Cribriform morula thyroid carcinoma. This is used to be papillary thyroid cancer, has been taken out from classification of papillary thyroid cancer. It's a distinct type of thyroid carcinoma. It's traditionally considered as a variant of PTC. It is driven by WNT beta-catenin pathway activation. It's frequently associated with the APC gene and seen in familial adenomatous polyposis. And these tumors do not express thyroglobulin, so it's completely different one. Previously was a subtype of PTC. So in general, this outlines the thyroid cancer disease spectrum from papillary carcinoma to PTC, tall cell variant, and this more aggressive solid columnar hobnail type of thyroid cancer, poorly differentiated and dedifferentiated, and then progressing to anaplastic type of thyroid cancer, from less aggressive to more aggressive. So when we see, with everything above that I discussed with you, when we see patients in the clinic after they have removed their thyroid, we have to put them, we have to re-stratify them, and we have to put them into 3 categories, which are typically low, intermediate, and high. And this is basically because that will help us to define how to treat them, how to follow the patients with thyroid cancer. And there are different types of there are different criteria for each category. So this is just a schema from low intrathyroidal that typically does not require any additional therapies and could be just observed, to intermediate that we debate whether radioactive iodine may be beneficial, to high risk thyroid cancer that typically universally treated radioactive iodine and require definitely more close follow-up and more aggressive management. And alternatively, way to think about thyroid cancer is the good, the bad, and the ugly. This actually kind of reflects also our classification. And with that, I would conclude my presentation, and thank you for your attention. And now I'm ready for the questions.
We have lots of questions on Zoom. The first question is, how likely is it for HCC to increase only 0.3 centimeters over 5 years? Is irregular borders change, minimal vascularity after 5 years enough to warrant removal?
The 0.3 centimeters grow over 5 years, that's definitely very minimal growth. More than this, a 3 millimeter growth within, that's basically, we say that it's stable. The thing that it's really, my question is, how do we certainly know that it's HCC if we not remove that? I mean, hypothetically, we think that this is a lesion that we think that HCC and we think that could be removed. Depends on the size, I would say. If it's really something, 1.8 centimeters is a smaller size, I think that this is okay to watch, but again, the age is important, and I would be, but if it definitely would be lesion more than 4 centimeters, I would be definitely more careful with that. I would not leave it alone if it's minimal growth.
So I had a Hurthle cell tumor, 4.2 centimeters, fully encapsulated, minimally invasive, less than 4, angioevasive, negative lymph, no extrathyroidal extension. I have the other side still. This was 5 months ago. My endocrinologists were watching it very, very carefully. What's your take on that?
It is very challenging because with the presence, if you would not have the lobe there, it will be easier to follow with thyroglobulin level. However, the lobe is there and thyroglobulin level monitoring becomes not as reliable, particularly if you have antibodies, that becomes even more complex. Just based on what we know, typically it's okay to leave that lobe alone, okay, and follow. I would see what is your baseline thyroglobulin level. If it's very, very high, if it's somewhere around where it's expected to be, like 20, 30, that's appropriate for the existing functional lobe. However, if it's going to be extremely high, more than 100 or 300 or thousands, then definitely that would be a very worrisome sign. These cases are very challenging, and it makes me nervous when the tumor gets, the bigger it is, whether they were able to fully examine the capsule, and even like with the small, like you don't have any vascular invasion, or you don't have, you have like
less than 4, and he said he's going back to see exactly.
So that's what like I like to see, because 3 will make me definitely more nervous than 1. So it's you know, like with everything that I said, it feels like we really understand and we really put it in boxes, but there is nothing, you know, like ultimate, and there is always like that, there is always a spectrum of disease, and there is always gray zones. So it's very challenging, particularly you are very young. So there is really, so far, based on what we see, yes, it's okay to follow, but it's definitely, I have patients like you in my practice, and it's definitely, I'm worried about that. However, I know that it's okay. And typically the one who, even if there is even, like the one that if there would be worrisome progression, like they typically would be already there at the time of the presentation. So if it would be already spread, you will already see that,
Okay.
and probably TG will be consistent with that. So you already treated your cancer. So
Okay.
I think it's okay to leave it there, but it's definitely in that gray zone, but becomes challenging.
And Hurthle cell, does it typically go to the other side, or once
No,
you? Okay.
that's the one that papillary thyroid cancer is actually could be frequently 30% could be seen multifocal in both lobes.
Okay.
That is typically solitary lesion. The other challenge that you have to think is that Hurtle's oncocytic thyroid carcinomas, they're not sensitive to radioactive iodine. So even if you remove that lobe, the point is typically to treat you with radioactive iodine, and that will that's supposed to help you to improve recurrence, like improve maybe mortality. But however, if it's not sensitive to radioactive iodine, removal, that becomes even more, decision about becomes more difficult. So really removal of the completion thyroidectomy will means that we'll have the really good marker to follow, and that's probably the biggest advantage to the biggest
reason to take the other side. Yeah, that's exactly what my endocrinologist said. So that's good to hear. Thank you.
So is there Hurthle cell hamartoma connection in someone who does not have PTEN gene? So typically PTEN gene is associated with, could be seen in tumor hamartoma syndrome. So if there is PTEN germline mutation, then that means that the patient will be predisposed to follicular thyroid cancer. On the other hand, sometimes PTEN mutation is diagnosed on the nodule itself, then germline PTEN mutation needs to be seen. But regarding connection of Hurthle cells can be seen in any type of follicular lesions, that in any type of thyroid lesion. So it does not thyroid nodules. It does not necessarily mean that it's Hurthle cell carcinoma. So I think that the Hurthle cell needs to be interpreted independently of PTEN gene. So what else? Maybe we can do one more. What do thyroglobulin levels and TSH level tell us, if anything, about the extent of papillary thyroid cancer disease at the time of diagnosis? Preoperatively, obtaining thyroglobulin levels is not really as meaningful, because bigger tumors will be associated with higher levels of cancer markers, and it does not it's not as helpful after surgery. 6 weeks after surgery, with the normal TSH or lower than normal TSH, that will be thyroglobulin level correlates with the volume of disease and definitely helps us to understand where the cancer is. Typically, the levels less than 5 are associated with the disease in the neck. However, poor TG producers like undifferentiated, poorly differentiated, high-grade tall cell variants could be not really as may not have good TG levels. Higher than 10, 15 is we need to look outside, but it's difficult to say because it has to be interpreted in the clinical setting. We need to understand what were preoperative imaging, what extent of disease was resected, is there anything left behind, what type of tumor it is, how well it produced thyroglobulin level, what is the TSH level, how soon after surgery is done. So it's very, you cannot really give the one answer to that. Would BRAF positivity and micro-PTC status post-thyroidectomy change management? Typically not, because most of the papillary thyroid cancer are driven by BRAF mutation, up to 70% of that. So when we think about papillary thyroid cancer, we actually think about BRAF V600T. So in the absence of other worrisome findings, that should not really drive, BRAF V600T alone should not drive the decision for completion thyroidectomy. Okay, one more. If you have classical PTC, can it morphologically be a different variant if left untreated? Could be, because there could be initially PTC is driven, let's say, by BRAF V600 mutation, but acquiring of additional mutations such as third TP53 will lead to progression to tall cell variant. However, majority of papillary thyroid cancer remain stable and don't acquire that mutation. So it does not necessarily mean that if that classical PTC, if it will be left behind, that it will definitely progress to more aggressive subtype. It can, but unlikely.
And with that, we will end the session. Thank you for all the people that have attended, and thank you for your time, Dr. Tarasova.
Thank you.
Have a wonderful conference.